All righty. Good afternoon. I'm Bill Zemsky. I am one of the board members for Childkind, and this is an exciting event for us. This is our annual Community of Practice webinar series, but our annual Maureen Strafford lecture. It will be presented by Neil Schechter, who will be talking about communicating with children and families about chronic pain. But first, I just want to talk a little bit about Maureen first. And I want to thank Maureen's husband, Alex, for being present in the audience today. So today's lecture honors Maureen Strafford, a vibrant pain champion whose passion lives on in the work that we do to improve humane care for children. Maureen was a remarkable pediatrician who was trained in multiple areas, including pediatric cardiology, anesthesiology, and pain, and was at Boston Children's in Tufts. She was an outstanding clinician and later in her career focused on mindfulness training in children, not only for pain, but to maintain health and balance as well. Her focus on humanism in medicine led her to be a prime mover in the development and spread of the white coat ceremony, which is now used in most medical schools around the country. She was a wonderful, patient, and kind teacher and a role model for generations of medical students and residents who now emulate the respect for patients and humanity that she brought to practice. This lecture series emphasizes topics and individuals which reflect those lofty goals. And I just want to mention on a personal note, I only met Maureen a few times, but people talk about a force of nature, and I can't think of anybody who's more a force of nature than Maureen. She filled up a room. She was dynamic, energetic, and also a bit of a whirling dervish. And so, when you think about all the natural events that we've had in the world, Maureen had a little bit of chaos and associated with her, which I think was one of her most endearing qualities, frankly. So with that, I want to introduce our speaker for today. Or first, I'm just going to mention a little bit about Childkind. It was founded out of the IAASP Pain in Childhood SIG. The mission of Childkind is dedicated to improving the quality of pediatric pain care around the world. We do this by certifying hospitals and other institutions, recognizing their commitment and excellence in pediatric pain management and to the well-being of children. And we also have an open access resource library that has protocols and guidelines that can be accessed through our website at childkindinternational.org. So now about almost to our speaker, but I'd like you to remain muted through the presentation. You can submit questions through Zoom in the chat feature, and we will be recording our lecture, and please sign up for our quarterly newsletter. And now I would really introduce our speaker, who's a great friend and mentor of mine, Neil Schechter. And those of you who don't know Neil or have not heard of Neil should just crawl in a hole because you haven't really paid attention for most of your life and your pain career. But regardless, Neil is really one of the fathers of or founders of the whole field of pediatric pain, and has spent his life really focused on improving pain care for all children. His systematic approaches to pain care have been emulated, but never duplicated, because really Neil is so far ahead in his thoughts about these things that it's hard to keep up. And he continues this work through Childkind as a diligent advocate for children. With that, I will introduce and allow Neil to take over the talk and talk about communication around pain in children. Neil?
Well, thank you very much, Bill, for that. This is the trickiest part of this. Good. So far, so good. Great. Thank you, Bill, for that very kind introduction. And it's really an honor for me to speak today at this lecture series, which is a homage to Maureen, who was a close personal friend of mine. And I know somewhere is watching this, and she should, this is all reflected glory of hers. So thank you to Childkind for allowing me to give this presentation today. It's about a topic that I think that she would appreciate very much, and that is communicating with children and families about chronic pain. So I have no relevant disclosures to make. This is a famous painting by the English painter Fildus, who was writing about painting this thoughtful, contemplative, avuncular-looking physician looking at a sick child and thinking how best to help. What's not evident from this, but is as important, is this. It's the father lurking somewhere in the background, worried, anxious, and for purposes of this lecture, worried about information that the physician might bring, and wants to hear something about what he thinks about his child. Obviously, it's critically important to parents. Anyone as a parent or is professionally involved with children is aware of the intensity of the emotions when we're dealing with a sick child. This is a famous painting by Munch called The Sick Child, but it's a reflection of the work by Singer, for example, who in 2004 did work looking at using fMRIs, looking at the anterior cingulate cortex and other parts of the brain that are associated with the emotion of pain, and found that when looking at pain in a loved one, the emotional part of the brain was as reactive in the parent or the loved one, in the individual who was loving as in the loved one who was experiencing the pain. So obviously this is sort of a critical aspect of when we deal with pain, and the communication about it, dealing with everyone associated with it is critical. So our take-home message today, and this is going to be really my focus, is that communicating with children, with families after a diagnosis of chronic pain is the first intervention in its treatment. The feedback that we're going to talk about in detail should be understandable to both the child and the parents. And during this critical period, when we're first making this diagnosis and first communicating this information and developing the relationship that should ensue, if the family and clinician develop a shared understanding of the problem, we can go ahead and start the healing process. But if that's unsuccessful, then very often doctor shopping will go on, and people looking for another explanation is very, very likely. There's even literature, for example, on the importance of that relationship that suggests that satisfaction in some studies, satisfaction with the relationship itself is more important than the actual reduction of discomfort. Okay, so what we're going to talk about a little bit today is a little bit about the nature of chronic pain, the importance of a multidisciplinary evaluation for its treatment as well as its understanding. And then we're going to really talk about the factors that make the communication about pain very challenging, and from both the patient side and the doctor side. And finally, we'll get into some nuts and bolts about the elements of the feedback itself. So this is acute pain, and this is what we're not going to be talking about today, but it's the type of pain with which everyone is familiar when you're experiencing pain. And this is what most parents and children would think about when somebody is experiencing discomfort. It's a discomfort arising from some sort of tissue injury. It'll typically last 12 weeks or so, depending on a variety of factors. Acute pain serves as a warning function. Something is wrong, something is happening here, and somebody should pay attention. And it signals a specific nociceptive event typically. It's self-limited and often accompanied by signs of sympathetic arousal. It's assumed that the level of the pain reflects the level of the tissue damage in some way. This is a sort of classic joke that everybody talks about it. For acute pain, this is theoretically an explanation of abdominal pain, porcupine emerging from the abdomen. This is for, let's say, widespread musculoskeletal or localized musculoskeletal pain, but both of those are acute pain, and again, not our focus today. What we will be focusing, however, is this arena over here, the centralized pain, which has many, many names, now known as nociplastic pain, primary pain disorders, and we'll talk about this label as we go on over the course of the hour. Okay, so what about chronic pain? Well, it differs from the patient's traditional understanding of pain in that it does not usually represent ongoing or current tissue damage. So there isn't a necessity of tissue damage associated with chronic pain. It's typically multifactorial, and there's not an obvious etiology. There's no shark, there's no porcupine present. And if there is an inciting stimulus, for example, if there is an illness or an inflammation or a trauma of one sort or another, that pain to be considered chronic has to last beyond the expected healing time. The pain doesn't prevent an accurate measure of the state of the tissues as opposed to acute pain, and it's not reflective in sympathetic nervous system arousal, which is why people will report a 10 out of 10 pain, and in fact not show the traditional evidence of that in their blood pressure or their breathing. Okay. And the hallmarks of chronic pain are that it is not particularly protective the way acute pain is. So the pain hurts, but is not typically harming, and it has a number of other associated symptoms. The pain occurs often in many locations, and in fact, there's an entity now known as chronic overlapping pain conditions, legitimized by the NIH having a working group in COPSEs, or whatever you'd call that. And clearly there's a number of overlapping pain conditions that associate together, but that is a grist for another meal. But there's often more functional impairment associated with these types of pain than there are with acute pain. There's orthostatic intolerance and a variety of other non-pain related phenomena that go along with it. And there's typically psychological comorbidities like anxiety and depression, which are associated with it. Interestingly enough as well, individuals with chronic pain often seem to be sensitive to a variety of other conditions, sometimes sounds, sometimes smells, sometimes increased sensitivities to medications. Another feature of chronic pain is that it's not really responsive to the typical approaches we use for acute pain. And finally, as I mentioned to you, there's a significant overlap with other pain conditions. So if one has a headache, for example, 60% of the time it's often associated with another pain problem, such as widespread musculoskeletal pain or abdominal pain of one sort or another. Well, there's been a lot of work on the nature of chronic pain over the past 20 years or so, and we now know that it's a very complex biopsychosocial phenomena and highly individualized. It's not a psychological or a biological problem, but clearly the interface in that arena. And it is associated very typically in other talks that you may be familiar with, and certainly ones that I've given. We know that it's associated with a highly sensitized nervous system, typically initially called by Wolff as central sensitization, that may result from many, many, many sources. So how does a nervous system get sensitized? How does it become vulnerable to have chronic pain? Well, as any number of factors may be responsible. For example, repeated nerve stimulation, repeated injury of one sort or another. There's work in newborns, and repeated needle skin breaking procedures will create increased sensitivity, which is broader than in the local area. In Ehlers-Danlos syndrome, for example, where there's repeated microtrauma of the overextension of the joints, that's another source. Infections of one sort or another that recur. Any types of repeated stress of one sort or another also may be responsible. There's obviously a genetic predisposition as well, and there's been a lot of work, and this isn't a talk to get into details about that, but there's a variety of genes and gene clusters that have been identified on arrays that are associated with chronic pain. More likely the epigenetics of it, the vulnerability to it, but not necessarily the pain itself at that time. And there's a whole a whole load of psychosocial factors that lead to diminished descending inhibitory control, often through the periaqueductal gray area, but that affects the impact of learning and personality and psychiatric and psychological problems on the pain pathways and makes one vulnerable to chronic pain conditions. It's the chronic activation of the HPA axis and the sympathetic nervous system as well. And those all lead to this situation in which there's the individual typically with chronic pain, and there's data for this on headache, there's similar data for this on abdominal pain, there's data for this on widespread musculoskeletal pain. And what you can see here is that on the x-axis, where you're seeing the intensity of the stimulus, for every stimulus intensity, the individual with chronic pain is hypersensitive and reports more discomfort for the same stimulus, whether that be a mechanical stimulus, a thermal stimulus, any other type of stimulus, than individuals who don't have chronic pain. That isn't so for every individual, and if it's very localized pain, for example, that's persistent, that may not be the case. But certainly with chronic overlapping pain conditions, very often we will see a centralized sensitive, hypersensitive nervous system. Okay. Then what happens typically is that there is some triggering event that occurs in a vulnerable nervous system. This is some work from our abdominal pain clinic by Beate Beinvogel and Sam Nurko. And what they found was proximal to the onset of a pain problem, onset of abdominal pain or the onset of whatever in an individual, a specific individual, they often will find either a GI infection that dissipates but has triggered this problem, psychological stress event. We found concussion. Again, many of us in the clinical world have patients report to us these events like a vaccination or a physical injury or psychological stress of one sort or another. And we tend to be somewhat, especially around concussion and other things, somewhat dismissive sometimes that causes the onset of discomfort. But more than likely, that's a stimulus, if you will, a trigger in an individual with a vulnerable nervous system. This is a schematic that I like to show. And what we see here is the biological predisposition. And we talked about genetics or microtrauma, adverse events of one sort or another. We ourselves have done some research on temperament, other sorts of stressors, as well as psychological influences like genetics or early life stressors of one sort or another, social modeling within families, other mental health problems, create this vulnerability, as you can see. And that vulnerability exists and then is triggered by some other event, an infection, an inflammation, an environmental stressor of one sort or another, psychological stressors, trauma, like concussions that I mentioned. And then we end up with a kind of nociplastic or functional or primary pain disorders, whatever name we're going to call them. Again, we'll talk about that in a little bit. And they can cause what used to be called functional abdominal pain, but is now known as disorders of gut-brain interaction or headache or widespread musculoskeletal pain. And again, the impact of psychological factors is certainly transactional in this. Okay, so we then would agree, or I hope you'll agree with me, or I tried to present, that pain results from, is maintained by, is magnified by, and impacts multiple domains in life. And as a result of that, no single intervention can address all of these aspects. The evaluation needs to be multifactorial and treatment needs to be multimodal. And there's an extensive literature. This is some work from Dennis Turk early on, but there have been repeated studies since then that suggest that as opposed to a unidimensional evaluation in which there's a single focus either on drugs or on surgery or on procedures or even on strictly psychological interventions, that they're not nearly as effective as as multimodal treatment, which is associated with a reduction in medication use, subsequently less healthcare utilization, improved functioning, reduced surgeries and hospitalizations, and generally better adherence to recommendations. This is some work from Gachel that looks at clearly the expense associated with chronic pain and disability when one's looking at a single intervention, a conventional, a procedure, for example, or just drugs, as compared to a comprehensive evaluation. And one sees a significant difference in both healthcare and disability. Okay. So our focus today is going to be on communication around chronic pain. But when we approach it, we want to review the records in detail. Obviously want to do a history and physical and with input from multiple disciplines. And it may be that the individual who's collating this, who's thinking about this, who's integrating the information from various providers is the individual who brings that all together, would be the general contractor, if you will. And then after there's this sort of detailed history and physical and the assumption that this is not a diagnosis of exclusion, but that we're dealing with a primary pain disorder, then the initial feedback session describing chronic pain and the model, and then getting into a rehabilitative approach using multimodal strategies. What I'm going to suggest to you is that the initial feedback is where we capture people, where they are most vulnerable to, most sensitive to their feelings and what they're hearing from the physician. So patients who come to us typically have seen many, many doctors for these kinds of problems. Most patients assume that chronic pain is treated like acute pain, and they expect a biomedical solution to their problem, not a wide-ranging, multidisciplinary approach. And they assume when one has a psychologist or other people addressing it, that one isn't really going to the cause of the pain, in fact, but is merely covering it up. And so they're looking for an explanation that's pretty biomedical. Therefore, it's critical that we provide a context to understand this, that it's a biopsychosocial phenomena that needs multimodal treatment. Again, how the information is shared and the patient's understanding of that information impacts on their compliance with recommendations, their satisfaction, and their pain ratings. This is some work from Stones a while ago. He interviewed 100 women 6 months after initial consultation for chronic pelvic pain. And what the women remembered was the doctor's affect and the appropriateness of the information provided at that initial consultation. And that predicted satisfaction, ultimate outcomes, and the level of pain they subsequently reported. In our abdominal pain clinic, in some work that Julie Snyder did, 33% of the families reported that the most important thing they got from that evaluation was the explanation that was offered for chronic pain. That was the most important intervention for them and the most helpful. Okay. But there are a number of things that can interfere, if you will, or complicate the communication about chronic pain. And first, I'm going to talk about those things from the physician/clinician side, and then we're going to talk about them from the patient side. And then we're finally going to really get into what we should talk about when we do this. Okay. So certainly something that people pick up on and is important for physicians to recognize are attitudes towards the disease and towards the patient. A number of physician attributes themselves. We'll talk about optimism and pessimism, the residual medical doubt that many of us experience when we're moving towards this sort of diagnosis, and finally the label. And those are all factors that complicate the discussion. So what about attitudes about this? And we know that there are, all of us bring implicit biases to medical care. And there have been literally hundreds and hundreds and hundreds of studies which suggest that physician attitudes towards individual human attributes may impact care. And this studies on differences in response to people of different sex or different gender, to different cultures, whether to socioeconomic status, to age, to race. There's a whole lot of different biases that are not malicious in any intent, but just implicit in normal human interaction. For example, there's studies in the emergency department about morphine use prescribed for long bone fractures, depending on a variety of factors. There's work on sickle cell. There's a whole host of those things. Chronic pain is particularly prone to individual bias, if you will, because the reporting is subjective. We don't see obvious evidence in the clinical picture, evidence of anything wrong. And so it's particularly prone to implicit bias. And in fact, this is a study of Texas neurologists, nothing specific about Texas here, but a bunch of neurologists at a meeting placed functional pain disorders when they were asked about what they like to treat and don't like to treat at the very bottom. They also dislike dizziness and low back pain and insomnia as well. And interestingly, not in that study, but in a related study, that dislikability or unlikability of the disease itself spilled from the symptom to the patient and reflected on his or her character. So what they found was that the more the symptom was not explained by the disease process, the more difficult the neurologist found the patient. So 82% of neurologists rated patients with functional disorders as at least somewhat difficult to deal with, as opposed to 25% of the group who had clear-cut neurological pathology. Okay. That makes it all the more important when we're dealing with these complex things for how the physician presents, if you will, or the clinician presents, the attributes and qualities that they bring to the table. There's quite a literature on if physicians are optimistic versus pessimistic about how people do with post-procedure pain, for example. There's also a very interesting literature on physician empathy. And if the physicians seem to be more empathic, patients seem to do much better. Let me just review a couple of those studies because they're intriguing. So empathy obviously involves understanding the patient's experiences, concerns, and perspectives, and being able to communicate that we understand that to the patient with the intention that we want to prevent suffering and relieve it. And patients with chronic pain, as I implied to you, present a real challenge for maintaining any empathy. They're draining very often. They're upset, they're worried, they've gotten different explanations for their problems. And there's a difference in the explanation that we have to offer them, which is typically that this is a chronic problem that we'll need to tweak and deal with over time and walk the walk with you, as opposed to making it go away. So patients might have different goals from the clinician, and it's a challenge to the physician or clinician's self-esteem and professionalism, because these problems are chronic. They don't just go away. We see them time and time and time again, and that's a very different model than what we're used to in dealing in many medical problems. So some Spanish work from Carnovus and some very recent work in JAMA by Licciardone looked at physician empathy and a number of patients. These were large patient databases, and they found that the more empathic the physician was, there was a greater reduction in average pain intensity. There was improvement in health-related outcome. There was, again, better outcomes found with empathy than non-pharm treatments, opioid treatments, and lumbar spine surgery. It had more value than all of those interventions. This is some intriguing work by Ted Kaptchuk that I like to mention very often. And what Kaptchuk did is he looked at a couple of hundred patients with irritable bowel syndrome, and they were assigned to either a waiting list or sham acupuncture with what they call limited intervention, meaning that the acupuncturist would walk in, do acupuncture in an area that really wasn't classically associated where their injury was or where their problem was. And they were limited in their interactions. They were curt, not rude, but very limited in terms of their interventions. And then there was another group. The third arm was sham acupuncture with augmented, meaning they would talk to the patient in a little more detail, ask about them, ask personal questions about them, demonstrate some interest and warmth. The more empathic, the warmer, and the more attentive they were, was then looked at in a variety of measures. And they found that the more empathic group, if you will, the augmented group, in terms of relief in symptoms, was very significantly different than either of the other two in symptom severity, as you can see, in quality of life. But they even found significant differences in the outcome based on the practitioner, regardless of their script. So if the person with limited, who was theoretically assigned to the limited group, displayed empathy, even though they had a specific script, clearly they had a better impact than the group that didn't. Okay. Additionally, there are a whole host of other reasons why this is so challenging to us. We aren't trained in how to talk to people about these kinds of problems. We lack the time and resources to spend with these sorts of difficulties. And with chronic pain patients, as I mentioned, physicians are typically less satisfied with their outcome. They report typically a poor therapeutic relationship. They feel guilty about the lack of success, and they feel it's kind of thankless very often. Patients are frustrated, they're angry, and they often don't leave feeling very good. Okay. Finally, a couple of other things that are important to think about. Typically, when we're dealing with chronic pain and talking about it, there's a reversal of the normal order. Not infrequently, we'll say, well, instead of you have X, which is what our usual thing is, well, we've ruled out all the big things. You don't have X. And that is very unsatisfying to patients, and it's pretty unsatisfying to patients, to the physicians as well. And again, for patient purposes, they can look up on the internet and find many, many things that we didn't test for. And therefore, a diagnosis that's not of exclusion, but is a diagnosis of the entity itself is very important. And finally, two other things. There's the fear of missing something, which haunts most of us. And that, of course, is balanced by the risk of doing iatrogenic harm, which I've called Munchausen by doctor, the repeated testing over and over and over again, trying to find something. And where patients believe that at the next diagnostic window or next diagnostic door, they'll find something that's explaining their problems. And finally, the diagnostic label, which I'm going to talk about in a minute. So what about doubt? And there's a difficulty knowing when to stop the investigation for common problems. Unfortunately, there is a lack of consensus on the level of investigation necessary for many symptoms. And fortunately, some professional societies have jumped into the fray and have developed algorithms. The Rome group for functional abdominal pain, and I'd urge you to look at their work, has developed a whole host of algorithms for common GI symptoms that gives you a sense when we should bail or when we should look at something else if we're not gastroenterologists, and when we should refer and what we should do. But in general, we search for alarm signs during the history and physical. We search for screening labs that suggest systemic disease. If the symptoms are highly localized, if there's fever, obviously signs of infection or inflammation, poor growth, weight loss, coupled with signs and symptoms that are usually associated with functional disorders. And again, this isn't a lecture to go into that, but just as many of you know, the vague and prolonged symptoms for many months, significant functional impairment, family history of functional problems. There are a host of associated signs and symptoms with functional disorders. If there are no alarm signs that emerge, and they've had what we feel is an adequate evaluation, even if it's come from a specific specialist in the content area, and they are coming to you for additional information or additional support, then we know that we're in the area of, we're typically functional disorders, if you will, or primary pain disorders. And then there's no downside, significant downside, to move on to a rehabilitation approach, because of course we can continue to search for physical disease if there's a change, a traditional disease if there's a change in the symptoms, but at least we can begin a process. Okay. All right. Again, how much to test is very individual and depends on your level of confidence. But we do know, for example, in some work done with dyspepsia, that patients who were initially had what was known as a low health anxiety, if we did the endoscopy, they were satisfied. If patients reported a high health anxiety in the beginning, they might have been reassured for 1 week. And actually, it was 1 week in this particular study. And then they were out searching for other explanations because the single endoscopic examination that said there seemed to be nothing wrong with their GI tract that could be visualized was not adequate. There's similar data for headache. And the literature suggests that the best form of reassurance is, of course, to suggest familiarity with the symptom, provide an understandable, explanatory model to the families, and arrange for frequent follow-up. And again, we're going to discuss all these things. Finally, in terms of the things that complicate this for the clinician, it's the whole arena of the name of these entities. And chronic pain disorders have suffered from frequent shifting of their names. And many times the names were the result of shifting assumptions about etiology. For example, hysteria and psychosomatic and functional all seem to imply that the problem is psychological in origin. And again, it's not. And as I tried to imply, it's a complex phenomenon. Similarly, medically unexplained pain, when we now do have an explanation for this, that it is probably the result of some sort of centralized hypersensitivity that may result from inflammation or neurological inflammation, unexplained neuroinflammation, but it's not medically unexplained. So we clearly have labels that have been problematic. And no label to date, although the most recent one does, no label does incorporate the 10 years of research, which suggests that chronic pain, as I implied to you, is a complex biopsychosocial phenomenon. To address this, the ICD-11 now suggests that there are things that these entities are known as primary pain disorders or chronic primary. They're etiologically agnostic. They don't suggest an etiology for this, but the fact that the pain is the disease, and that is what we are treating. This is the schema by Nicholas, the work by Treaty and others, working very hard at this classification. I know it's very hard to seek this in this, but basically it starts at the root of the tree is sort of this chronic pain problem, and then that secondary where the pain is the disease, and then it branches out into the variety of pain problems that we're all very, very familiar with. Okay, how about that was from the clinician side? How about from the patient side? What goes on in this exchange from the patient side? Well, obviously, there's expectations of a cure. There's their previous experience. There's a host of attitudes that patients bring to this, and then there's social concerns about the diagnosis. So patient expectation is clearly a problem. If they think something's going to not be helpful or hasn't been helpful, or the parents feel that they've tried that problem, that thing hasn't been helpful, then they're not going to be successful. There's an extensive literature that supports the association of pre-treatment expectations and ultimate outcomes. If people think it's going to work, often it is more successful than if they don't think it's going to work. And early treatment failure in the course of a problem will contribute to the expectation for future treatment failure. Let me show you, this is some work that we did a very long time ago, but I think it speaks to the point. We were looking at the impact of an oral transmucosal opioid on painful procedures in kids. These are when kids are having bone marrow aspirations. This is before it was routine that we sedated them. So we used a placebo lollipop, if you will, and an opioid lollipop. And as you can see, far to the left and the y-axis, if we were using either the oral actual drug or the placebo, there was more pain associated with the placebo, obviously. However, for all subsequent procedures, these were kids with cancer who were having multiple bone marrow biopsies. For all subsequent procedures, we used active drug. Yet the people who had the initially negative experience for all up to 4 procedures reported more pain than the group that had the positive experience. So they were somehow a set point change, and somehow there was they could never trust. And these were kids under the age of 8. Over the age of 8, we could have some impact, but for younger kids, we were unable to change that initial impression. Additionally, we're talking about the lack of public understanding of this entity. There's an invisibility of chronic pain, and there's a literature on invisible handicaps in general that goes along with seizure disorders and other entities where people just don't understand if they don't see the handicap. There's a lack of supporting hardware evidence of a problem. There's often lots in the literature on alternative diagnoses. And there's as well a societal unacceptability of anything that smacks of having a psychological contribution. So as a result of that, we end up in what Kenny has called this chasm of communication, where the patients tend to believe that pain is basically biological in its origin. It must be, my body hurts so much. And they want the pain to be legitimized by finding some underlying etiology. And they're invested in convincing the doctors of the physicality of their pain. In this study that I've mentioned here, patients with an inflammatory pain highlighted the importance of being seen as an individual, but an individual who happened to have a disease rather than a case of something. And that was not so with individuals with non-inflammatory conditions who wanted physicians to believe that the pain was physical, and they wanted to be considered a case of X, Y, and Z. From the doctor's side, of course, we want to convey the notion that there's a psychosocial contribution to this factor, that bodily symptoms may be impacted by psychological stress. So we begin this conversation then with very different assumptions. And when the consulting room door closes, we have a lot of ground to make up. And in fact, we don't often do a good job. This is some work that suggests when there were explanations offered for chronic pain, that many children believed it was false. And this is some work, more recent work by Navo. Again, that's suggested that doctors must be missing something. They're haunted by that. They're searching for alternative diagnoses. This is the cartoons developed by the Rome Foundation, and what they suggested. This is what the doctor's thinking. Here we go again. My afternoon is shot. These people are crazy. How can I get rid of them? Maybe it's porphyria. I'll order some more tests. It's going to kill my whole afternoon. Maybe I should treat for porphyria. And the parent side is, God, I hope there's nothing wrong. I want the doctor to find something. I want some more tests. She loves school, has many friends. It can't be any psychological contribution. And the kid's saying, I don't want any more tests. Get me out of here. I don't even know why I'm here. Nobody's going to really help me. Which leads to this sort of thing. There's no easy way I can tell you this. So I'm going to send you to someone who can. And that someone is you, my friends. And hopefully we can be the people who can explain these conditions to families in a way that they understand. So what are the elements of an adequate feedback? Well, I would suggest the first thing is to elicit patient expectations. What do they want? What are they looking for? We want to reduce their anxiety, and all of that shows if we ask about expectations, it will improve satisfaction. We want to report our familiarity with the problem. Your symptoms make sense to me. You come to the right place. This isn't a mystery. It fits a pattern that I'm familiar with. And a line that we tend to use is, you may be unique, but your symptoms are not a mystery. Okay. Then we want to say that it's not, I believe you. You're not making this up. It's not in your head. We want to offer a positive diagnosis. This is an entity with which I'm familiar. And we want to validate the symptoms as much as possible. It must be frustrating to have so much pain. I wonder how you've been able to manage doing what you've been doing. We want to validate how challenging this has been. And finally, we want to offer an optimistic appraisal of outcome. And there's some legitimacy to that. It's not just Pollyannish. Most of the time, these conditions don't continue on into life at the same rate or same level into later life. There's a strong potential for reversibility in these conditions. And we want to say many children do very, very well with these disorders and have a full, productive, and happy life. And these set of elements of a feedback will be very, very beneficial in developing the kind of warm relationship, empathic relationship that's critical. So what we want to do is reconceptualize the pain from the medical model, in which tissue injury or tissue damage is what people are thinking about, to a biopsychosocial model where pain is the disease and has multiple causes. We want to, again, assert that tissue pathology doesn't explain the pain. The pain is hurtful, but not harmful to you. And as we're going to talk about, it's a software and not a hardware problem. And again, we want to emphasize the importance of patience and pacing, that this is going to be a process. We're going to walk this walk together. It's going to be frustrating, perhaps, but we're going to start a path together. Okay. Something that's very critical is the use of metaphors, and this is something we've thought quite a bit about. And again, what we want to make is this distinction between acute and chronic pain, and we want to get it out of the area of, if you will, the psychological versus the physical. And the model that we typically use is a computer software model. And in that model, we suggest that clearly that if your computer's not working very well, and we'll say this to the child who's typically an adolescent in our world, but even if they're pre-adolescent, they understand it these days. If your computer's not working very well, we'll typically reboot it. But if we opened it up and looked at the motherboard, we wouldn't necessarily see anything wrong with the hardware. The problem is in the software itself, the error there. And that is where your nerves are hypersensitive and overreactive. Another model people use is a false alarm model, where the alarm is going off. The nerves of the alarm system, they're going off, but it's a false alarm. There isn't tissue damage. They're not doing what they're supposed to be doing. We'll often use a sunburn model where, if you tap on your arm now and it doesn't hurt, but if you're sunburned, the same tapping, the same amount of tapping is much more painful. And Gallagher has looked at that, and some other folks have looked at the use of metaphors and found that there's a better understanding of pain in the metaphor group when we do that. So here's a couple of helpful hints before we finish. We want to recognize our own implicit bias in this situation, the importance of our positive attitude, our optimistic attitude. We want to suggest that the evaluation is adequate to provide some reassurance, but not so much as to fuel the desire for further testing. The more testing we do, the more testing we're going to do after that, because we'll always find something unusual potentially, and that will again continue the investigative assembly line. As I implied to you, the feedback is the key. It either elicits compliance or further doctor shopping. And it's very important to query, at least initially, patients' expectations. We want to prepare people for negative tests. So if we decide to do a variety of scans or whatever, we want to tell them that we're doing this. We don't anticipate it's going to be positive. And we know what the problem is, but for sake of completion or whatever else phrase we want to use, we are doing this diagnostic test. But we want to prepare them for negative results so they're not hanging, waiting, looking at the portal for the results that might explain their problem. The implication is we know what the problem is already. The diagnostic label is less important than we convey a positive diagnosis. And we want to not dichotomize. We don't want to make it a diagnosis of exclusion. Again, you can always exclude more and more and more things. And all of you who work in this field know that the internet is rife with a variety of rare diagnoses that people say, see, they found this 1 in a million diagnosis, and I'm sure maybe this was what my child has, as opposed to what you're suggesting. We want to use metaphors, and multiple may be required. We want to provide, if we can, written information explaining the model, so people can leave after this complicated discussion that we've had with something in the hands that they can reread. And we want to identify reliable sources of information for patients. There are lots of sources of misinformation on the internet, and we want to alert people to that. Finally, we want to be, and this is reiterating the same thing that I mentioned, we want to be sure that the feedback session includes the following things that I want to reiterate. I'm familiar with this problem. You're not unique, or you are unique as a person, but you're not a mystery to me. I've seen it before. So many patients have been to so many doctors, especially with overlapping pains, and have gotten different explanations for these problems that don't address the broader implications of school and sleep and everything else. And you're going to talk about the fact that you're familiar with this problem and you're not. That I believe you. I believe that this pain exists. It's not in your head. I believe you come to the right place. And finally, I'm optimistic. Children with these symptoms do extremely well. We want to arrange follow-up appointments that are reassuring to families. This has been quoted as listening to the illness, but keeping an eye out for the disease, if you will. So we want to be sure that if something is missed, assure parents that, if this changes, if the symptomatology changes in any way, we're going to be on the lookout for anything obscure or unusual that might change. But in the meantime, we're beginning a multimodal intervention that we expect to be helpful. Finally, from our perspective, from teaching others in our fields about this, there should be specific educational initiatives aimed at discussing chronic pain, simulations of telling news to families. There is a literature on teaching empathy, even though that seems somewhat oxymoron. And then finally, having crib sheets for trainees, scripts that help them discuss chronic pain in a logical way. And that's all I really have to say about this very complicated topic. So thank you very much for your attention, and I'm happy to answer questions in the remaining 10 minutes if there are any.
Neil, that was awesome. It strikes me that having spent a lot of time working with you, I still use a lot of the things that you've taught me today, and I'm sure members of my team who are on this webinar think that I invented all those, and clearly I didn't, but that's our secret. So we do already have a question. What is a question from Charmaine about acute on chronic pain? What's the best way to prepare kids with chronic pain for major surgery? What considerations for the acute care team?
That's a very good question, and not an easy one. I would suggest that we can anticipate that an individual who has a sensitized nervous system might be a little bit more reactive, prepare them for that, although we don't want to give a self-fulfilling prophecy, say that we're going to address the pain in the way that we have addressed it in the past, that we'll cover their acute pain needs in the traditional manner, and then we're going to put in all the other interventions that we've talked about. But again, prepare them for the fact that they may experience multiple symptoms because their nervous systems are so sensitive just in general. And that would be my advice around that area. Again, using as much as we can to prevent the pain, regional approaches and everything else. is probably the best thing that we can do. But in the interim, obviously, these are problems that we see very often, acute on chronic, not only with surgery, but with pancreatitis, with a variety of other conditions in which nervous systems are sensitized because of repeated pain, sickle cell. It's important to do the same thing, to address the acute pain in the way that we would, but anticipate that it might be a bit more pronounced.
Great. Alan Finley made a comment. Some parents and teenagers, when asked about their future plans, will say, she wanted to be a ... but will never be able to do that because of their pain. I always try to emphasize they shouldn't cross anything off their career plans at this point. They can still do anything they want in the future.
Great. That's exactly what I would say. Exactly.
Let's see. In addition, this is from Fiona Campbell. Regarding acute on chronic pain, in addition to Neil's suggestion, considering seen by a transitional pain service or acute pain service in advance to ensure good plan and managing expectations. Great advice, Fiona. Another question, in the Amesh family, do you address management for the family unit as a whole? If yes, how do you frame that for them?
Well, again, it's the same thing applies, that this is a family kind of concern. Parents, there's almost nothing worse than feeling helpless when your child is suffering. And so we want to convince them that we are treating this child's problem. Even though the pain might persist, we're addressing it in the best way that we can. Again, many of these families have been dealing with this for a long time. They either have a premorbid problem or a psychological kind of enmeshment, or very often have become increasingly enmeshed because of the constant searching for answers for this particular kind of problem, and the feeling of the parents to really protect the kid from this pain as much as they can. So for those families, again, it's very important to involve. Now, that is a good question because it's really challenging, because not infrequently parents will have experienced a similar kind of problem. So in the mother who has or father who has fibromyalgia, it's often a mother 80% of the time, then they might be problematic in that, say, well, I tried gabapentin and that didn't work for me, or I tried acupuncture and it didn't work for me. And then it's important to suggest very often, your child is different than you were. And there are new techniques that are available since you've been struggling with this particular problem. And your child only has half of your genetic makeup. It's bad if they both have fibromyalgia, but if only one family member does, then the goal would be, for the most part, to, as much as possible, suggest a new life for their child, that something's going to be different, and not to dismiss these interventions in a multimodal way, and to suggest that they only had one piece of this complicated puzzle, and we're offering multiple pieces simultaneously.
Great. Another question, are there resources you or those listening recommend to provide to kids or families? I'm thinking about apps or interactive websites. We see many kids with elements of chronic pain, and they are often limited in their ability to access a chronic pain clinic. We don't have one at our institution.
Yeah, so that's a very good question. I can't recommend them specifically. Maybe on the listserv, perhaps people can offer websites that they found to be reputable and helpful. Many of the hospitals have detailed discussions about these kinds of things that are quite beneficial as well. I certainly am empathetic to the issue that many hospitals cannot afford or don't have the resources or the desire to have chronic pain clinics. And that's really challenging. And I would suggest in those kinds of settings that people develop a cadre of individuals, not who see patients simultaneously the way they might in a chronic clinic, but instead to if you will, develop a cadre of individuals in their community who work together, who are sympathetic to these kinds of issues. And you'll often find, for example, a gastroenterologist, instead of who likes these kinds of problems or is good with these kinds of problems, as opposed to strictly one who might be more comfortable with IBD, for example, or psychologists who have some training in this, or use the comfortability model and develop a variety of other interventions. So I recognize promoting a multidisciplinary approach, but that's often not available in many communities. But certainly this approach is, and the development of resources that create a de facto team, if you will, even if they're not physically all present, is probably what I would recommend.
Great. Thanks, Neil. There's a bunch of references in the chat for those who are interested. I would be interested in running pain education simulations, as you mentioned, for my pediatric trainees. Do you have crib sheet references or shareable resources?
Nope. I don't off the top, but certainly any of the things that we've just talked about, if you would videotape one of your sessions with a pretend patient or even with a real patient, an empathic feedback session to model the elements that we've just talked about, that's fine. I did one, I believe, on the one of our websites at the at our hospital. I believe there is one where we did something with abdominal pain with a practice patient, if you will. I can find the reference, or someone's perhaps can put it on with the. I can't remember exactly where to find it, but I can certainly put it out there, if you will, if people want to look at that. But there should be many, many others available. And if not, make it up in your own world. All of you people have a lot of expertise, and many of you have been doing this for quite a while, and I would strongly suggest you make one that fits with the resources and the personalities that you have at your institution. But the elements that I mentioned should be present in all of them.
And it looks like Fiona put something in the website. I would also say that Neil wrote an excellent article with Rachel Coakley about pain analogies that I encourage you to pull. If you Google, it was in the Pain Letters. I don't know what year it was, but if you Google
2013, I think.
2013, it should be freely available online. And it's an article about analogies in pain with Neil and Rachel Coakley. I think I don't see any more questions in the chat right now, but thank you very much for joining. Remember, our website, childkindinternational.org, does have a fair number of resources on it as well, especially guidelines and protocols. There's a number of great books that people are mentioning and other resources. The Pain Listserv, for those who are not on it, is also a great resource where you can ask questions. That's run out of Dalhousie. So if you Google Pain Listserv Dalhousie, you can find that. So there's numerous resources, and certainly feel free to reach out to anybody. Any of the experts in the field will be happy to share information with you. And have a great rest of your week. Take care.
Bye, everybody. Thank you.